Hello, everybody. Welcome back to the Incubator Podcast, live at the CHNC Symposium in Denver, Colorado. We are joined this morning, still morning, I guess, by Heather Tubbs Cooley.
We're on Eastern time.
That is true. My computer has not adjusted yet. Who's coming to us from Columbus, Ohio, from Nationwide Children's Hospital and The Ohio State University.
Right.
Heather, thank you so much for dropping by and talking to us a little bit about the work you're doing in collaboration with the CHNC. Can you tell us a little bit about, you were saying you were excited to talk to us a little bit about what you presented here this time around. Can you tell us about it?
Yeah, well, thank you. Again, I love this podcast.
That's nice of you to say.
So I'm so excited to have the opportunity to chat with you. So I presented on some results of a study.
And not just presented, you had one of the platform abstract presentations.
I did.
So,
I did. I'm really
a spotlight.
I had a spotlight, which I was grateful for. So what I presented were the results of a study that we've been working on over the last 3 to 4 years, where we looked at the relationship between nurse workload in NICUs and how that impacts nursing care delivery.
So important.
You know that baby outcomes are, of course, a team sport.
Yeah.
But nurses really deliver the lion's share of direct care in the NICU. And so a lot of what they do...
There's no debate about that.
Yeah, no debate about that. And so I've had a long program of research looking at things like nurse staffing, but in this study we looked at a broader spectrum of indicators of nurse workload at the shift level and how that impacted what nurses missed for their assigned babies. So we're looking at core nursing care, things like surveillance, looking at checking the endotracheal tube ties. Those unplanned extubations are a real problem. Peripheral IV, if a baby's got a PIV going, are they doing hourly checks to prevent those extravasations?
So before you get into the data, then tell us what's the difference between nurse staffing and this concept of nurse workload?
Okay, so there is some difference conceptually.
Right.
So nurse workload is kind of the umbrella term.
Right.
And then there are different ways we can operationalize that or think about that. One of which is a lot of people use nurse staffing ratios because they're really easy to measure and they're already in the data.
That's right.
Right, that most institutions have. You can look at another indicator of nurse workload, things like acuity scores or nursing intensity scores, and those tend to drive nursing resource allocation in units. That's a common thing that some nurse leaders use is like a nursing intensity measure, and that determines how many babies get allocated to a single nurse. And then you can look at nurse workload in another way, which is the more experiential part, like in real time in a situation, how much intensity is this placing on a clinician?
Like maybe one baby is not the same on Monday as they are on Tuesday.
I think the nurse staffing is a big problem because you say, it's a one nurse to 2 to 3 to 4 patients, but it doesn't tell you much about the patients. You may categorize patients based on level of care. You can say this is a level 1 patient, level 2 patients, but patients are not static, they're dynamic.
Correct.
And status changes, and I think that the things that nurses are asked to do on a granular basis are very dense and very deep, and I think that sometimes gets missed.
It does.
In the staffing ratios that you can see a lot of times used. Yeah.
Yeah, and a lot of the work in the nurse workload in the NICU and in a lot of different places is really staffing driven. People look at ratios predominantly, and we wanted to take a more holistic, comprehensive look at workload broadly.
A more realistic look.
Yeah, I mean, most nurses will acknowledge a 1-to-1 with this patient is not always the equivalent of a 1-to-1 assignment with another patient. Sometimes the parents have needs. Sometimes there's just other things going on. Sometimes I could say I can handle 3 babies today because of the characteristics of those babies, and sometimes...
Yeah, it's possible that sometimes the 1-to-1 is actually not as complicated.
I have had many nurses who told me,
I
prefer the 1-to-1 because most of the time they're quote-unquote quite maxed out on a lot of the things that can be done to this baby, and so I know what to expect in terms of cares, in terms of delivery of medications. There's some patients you're like, I don't know what my shift is going to look like because this baby is doing fine now, but is a high potential for decompensation. And I think it doesn't take into account the state in which the nurse enters the work day or the work shift, I guess. Some nurses are on a long stretch. Some nurses are on their first day. And I think that impacts your bandwidth as to how much can you handle in that one shift, and how vigilant are you going to be able to be if you're on day 5 of the stretch, because they needed help. We've seen this in our institution so many times. They've been pulled several times, and in an attempt to be helpful.
Yeah, we're staffed, but at the expense of nurses coming in on their off days, on back-to-back days.
Absolutely,
and
absolutely.
Right.
Yeah.
Yep. And a little bit of backstory. So we've looked at this relationship between nurse workload, these ratios, acuity, and the subjective component in a prior study where we just had one NICU. And we found that actually the subjective workload of the nurse on the shift was actually more predictive of what they reported missing for their baby than the ratios or the acuity scores, which was not what we expected. We measured it because we thought it was interesting, but we didn't expect that it would really be the spotlight finding of that study. And so we thought, well, maybe this is just a really highly resourced NICU. There's not a lot of variability in the ratio, so maybe we just need to do let's look at it now across different sites and see if do we see the same thing. So that's what we did, and we kind of found very similar things, although we did see, in this data that staffing does come up a little bit more prominently, particularly when nurses have 3 babies or more.
Sure.
So we still see a staffing effect.
When you think about being a parent, right, and these are healthy newborns at home, having 3 of them is a lot. If you have to do all of them,
I'm struggling.
And right, and I mean, if we really. I'm not allowed to comment about staffing anymore in our unit because I've gotten in trouble enough times. But it's a lot what we were asking.
Oh, there's definitely a lack of appreciation for sure in terms of our nursing workforce. And I explained to my wife the pyramid of care in the NICU. She's like, "Aren't you supposed to be a neonatologist?" And I'm like, "You do not understand that nurses are running the NICU.
Bosses.
I am not.
In the NICU. Yeah, for sure.
I am a very small cog in this big wheel that is the NICU.
An important cog. Yeah.
So tell us more about what is going missed?
All right. So we looked at 16 different things that most babies would need.
Yeah.
And so this was level 3 and level 4 NICUs. And so we're looking at things like if the baby has a central line, are you adhering to the expected parts of the maintenance bundle, the CLABSI bundle? If a baby has an ET tube, are you surveilling that tube on a routine basis and making sure that it's not sort of looking like it's inching its way out? Are you were you able to hand off? If you did a handoff, were you able to include all of the pertinent information that was needed to make a safe handoff? So when it comes to what got missed most frequently. That's a good question. I really have to dig back in my mind a little bit. Things like discharge teaching. If the parents were there and the baby's starting to make that trajectory home, every opportunity that you needed to take for
that
discharge.
Could be done tomorrow.
Teaching, right? Yeah. So the clinical indicators of things like missing an hourly surveillance of a peripheral IV line, the things that nurses get audited on a lot were missed the least. The things that could be deferred, like discharge teaching, parent engagement. If the parents were there at the bedside, did you miss opportunities to engage them in the baby's care? That was missed. One of the more frequently missed things. Oral feeding opportunities. If that baby's ready to orally feed, but they're learning, and that takes a lot of time to really sit with a baby and work on an oral feed. So if you have 3 babies or several that are feeder growers, the thought is those are less acute babies, so you can handle more of them. But the typical oral feed, when a baby's learning, takes about 20 to 30 minutes per pop.
Yeah.
And so doing that every 3 to 4 hours per baby is that when you calculate the time, that's about 6 hours of time.
Yeah, that's right.
Yeah,
just on the tasks alone.
Yeah. So it's those types of things that are missed most frequently in the data that we have.
Yeah.
Thank you.
Very interesting. And a reminder for all of us for the incredible work that our bedside nurses are doing each and every day, and that I think even the NEOs can be advocates for our staffing support, because some of those pieces are critical to patient outcomes. Parent discharge teaching, parent engagement, and then some of those checks that on a one-off miss are not so problematic. But when we're talking about unplanned extubations, the OG tube is not venting well, over time they can become a critical event.
Yeah.
So very interesting.
Heather, thank you so much for dropping by and for sharing your work. Congratulations.
Thanks for the opportunity.
Of course.
Thanks for being here.
Yeah.
Thanks.